Hi, everyone. Thank you so much for joining. This is the International OCD Foundation Town Hall on OCD and Shame. We've got a great program for you tonight. I'm your host, Vinay Krishnan. Usually Ethan Smith hosts these. He's not in tonight, so we'll have to make up for the loss of his sense of humor. We'll see how we do that. But we got three great panelists for you who I will introduce in a minute. We're going to be talking about OCD and shame, getting into all kinds of issues. While we're talking, feel free to drop some questions into the chat. We'll try to get through as many as we can. We'll definitely make time for Q&A. So thank you all for being here. Just before we start, we have a disclaimer. Just so everyone knows, this live stream is intended to serve as educational content and is not intended to replace therapy. For treatment-related questions, please be sure to work with your local provider or contact a local clinician. The IOCDF is not a crisis hotline and should not be used if you're in distress or feel unsafe. If you are in crisis or you are ever feeling suicidal or unsafe, please go to your local emergency room, call 911, or call the suicide prevention hotline at 1-800-273-8255. You can see it at the bottom of your screen too. And lastly, we want to create as safe a space as possible and be kind and respect everyone. So with that in mind, this is being broadcast on various social media platforms and is being recorded. So please be mindful of that as you ask personal questions or leave comments in the chat. And at the end of the day, we're all here to support one another. So with that spirit in mind, let me introduce our great panelists. I'll describe them to you if you all want to say a quick hello, and then we can dive into our discussion. So first is Mike Heady. Mike is a licensed clinical professional counselor, and co-director of the Anxiety and Stress Disorders Institute of Maryland. He specializes in the treatment of OCD and anxiety disorders, runs regular group and individual consultations with therapists, and frequently provides education about OCD and anxiety through webinars, podcasts, and conference workshops. Good to have you, Mike. You want to say a quick hello?
Oh, hi, everyone. Thanks for having me on. I hope this is going to be helpful to everyone listening. It's a passion project of mine to talk about shame within OCD and its related conditions.
Glad to have you, Mike. And I see some folks are introducing themselves in the chat. Feel free to go ahead and do that. Let us know where you're calling in from. I'd like to get to know everybody. Next, we have Dr. Katia Moritz, who's a licensed psychologist in Florida, New York, Utah, and Rio de Janeiro, Brazil. Dr. Moritz is board certified in cognitive and behavioral psychology and a fellow of the Association of Behavioral and Cognitive Therapies. Together with Jonathan Hoffman, she founded the NBI Ranch and Neurobehavioral Institute, where she's the chief clinical officer. She specializes in the treatment of severe anxiety, OCD, and related disorders, and autism spectrum disorders. And you might be familiar with her because she authored Working with Obsessive Compulsive Disorder in Children, which is an audio and video training program, and also Blink Blink, Clop Clop, an OCD storybook, which has English and Spanish versions for children, which I think is definitely related to our topic today. So we're definitely going to bring that up. Dr. Moritz, do you want to say a quick hello?
Hey, everyone. Glad to be here. Looking forward to our discussion. Thanks, Vinay.
Thanks for being here. And lastly, we have Jelani Daniel, who's a doctoral candidate in a combined clinical and social psychology program at the University of Houston, Clear Lake. Prior to his candidacy, he worked as a licensed professional counselor in private practice at Baylor College of Medicine's outpatient OCD program. He has 15 years of experience being involved in treatment of patients with anxiety, OCD, and related disorders. And during that span, he worked at various OCD clinics, such as the Menninger Clinic and the Houston OCD program, which I think lots of folks are familiar with here. And he's a member of the IOCDF's Diversity Advisory Council, which I am as well. Jelani, did you want to say a quick hello?
Yeah, just thank you for having me. It was really a pleasure in being here. Look forward to the discussion and hope you all find it helpful. And shout out from Houston.
Yeah, props to Houston. And for those folks who don't know me, I'm filling in for Ethan. Vinay, I'm over in New York. I'm the national field organizer at a nonprofit working on healthcare issues. I've lived with OCD all my life, and I also write about it. So you might be familiar with that. So let's dive in. We're here to talk about OCD and shame. I really want to pick all your minds because you're all brilliant. And obviously all mental illnesses come with their own variety of shame and stigma. But I think OCD in particular is very much associated with shame. I often hear it called like the shame disorder. So if anyone wants to jump in, I'd love to just talk a bit about why we think OCD is so particularly associated with shame, maybe more so than other illnesses, and how you've seen it in your work.
I can start us off. I think I have heard that before too in the past, of so much of how OCD, referring to OCD as a shame disorder, I think it really stems from the experience of the intrusive thoughts and the obsessions, intrusive images and whatnot that somebody might experience, and really in terms of like the meaning that gets attached to these experiences and believing that, if I'm having these thoughts or I'm having these images, this means that I want to do these things, or this means that I'm a bad person. And so then all that shame then is attached. I think one thing that we should also early on is distinguish, because I think a lot of times people may not understand the difference between guilt and shame, is that, guilt is more of this type of like external evaluation of our behavior and saying like, this thing that I did was bad, or, like this is a bad, behavior or whatnot, as opposed to shame is more of this internalized, this, internal direction of that evaluation and saying, I am a bad person because of this. And so then what you often see within OCD is, again, like the interpretation of the obsession of like, oh, if I have this intrusive thought, and this means that I must be a bad person. And so there's like kind of like thought action fusion, that goes along with these experiences, can lead to like this experience of shame that we see so much and so intense within OCD.
Yeah, I think that's a really fantastic point. Sorry, I didn't mean to cut you off.
No, I was going to turn over to you, Mike. So you go ahead.
That separation between guilt and shame is a really critical distinction. So I'm glad you brought that up, because there's a lot of it's sort of used synonymously in casual conversation. And I think the work we try to do is try to recognize that that they are quite different experiences for people, especially when you're talking about like what makes, say, OCD or depression worse, right? We know that shame does that. Guilt is a little less likely to. The research on that suggests that guilt is, like you had said, much more focused on like, I did a thing and it may have harmed another person, and I feel like I need to repair that or apologize for that or seek some kind of reconciliation for that. But shame is so much more focused on that self, and we don't tend to make this attempt to reconcile with ourselves, right? We think about, at least I've seen this, I don't know if your guys' experience is the same, that a lot of people have what I'd call maladaptive shame, right? The shame where it's a global condemnation of who they are as a person. They wear it like an identity. So if I have this intrusive thought that's taboo, that is attacking me as a person and my entire self-worth, they don't see the shame as this sort of like, the potential that shame could have is that we could relate to it differently. It could become something more functional, right? And I'll turn it over to other people in a comment, but I certainly have a lot more that I can say about that.
So I have a few things in mind. One is, I always find it fascinating that people would think that because you have a brain-based disorder, you should have the control over it. And so I think that the whole thing about why certain brain conditions are so stigmatized is that there is this connection that if it's in your head is because you have volition and ability to stop it. So you're almost choosing not to, right? And I think that some of the stigma, embarrassment, or feeling is that people see themselves as failures because they weren't able to do that. So people are going to see me as weak and less capable because I wasn't supposed to. And my position on this is, your brain is the most complex organ in your body. And so if your liver is not working, or if your kidney is not working, or if your pancreas is not working, it's a big problem. But they control a few little tiny functions, each of them. And then you take the masterpiece of your brain and your brain is not working the right way. And all of a sudden you think that that's going to be your own volition and your own choice. And that's really the reality. It's not, right? And so I think that the concept of the OCD is because there is this misperception that we control our thoughts and feelings. And if we're having thoughts that we don't want to have either, and they are intrusive or weird or whatever, like everyone else has it, but we don't want to have them, all of a sudden it becomes a much more almost like, well, then because I'm supposed to control it, maybe I am controlling it. Maybe I could have not had them, right? And so I think that when you talk about shame, Jelani, and regret is, for me, one interesting concept to bring to OCD folks, which is, yeah, I feel really guilty. I had that thought. And I was like, do you regret it? And people are like, I don't control it. How can I regret it, right? So I think, Albert Ellis is always to say that, guilt is an irrational and a maladaptive feeling because it doesn't help you change anything. You feel it. You can feel guilt for things you've never done, right? And the question is, when you ask yourself, and of course, in those OCD, you have to be a little careful because you don't want to make a compulsion out of the regret conversation, right? But understanding that big concept of how the feelings are, once you don't control it, right, then you have to let go of that feeling that could be maladaptive. So I think that there's a really beautiful understanding that when the world really embraced the fact that mental illness or mental based conditions have nothing to do with your choice, have not the opposite, right? It's just something that no one wants, no one is asking for, and no one is trying to control and failing to control. I think that will allow us to lift that perception much faster than we have in the past.
Yeah, and it's great to hear from 3 clinicians on that. And I love that you mentioned like thought, action, fusion, because as someone who's lived with OCD, I feel like one of the most pivotal moments in my treatment was when I realized, oh, having violent thoughts doesn't make me a violent person. Like having inappropriate thoughts doesn't make me an inappropriate person. It's like what thoughts you choose to act on. And if anything, like when my intrusive thoughts come in, my anxiety rises, right? Because I fear these things, which means they're against my values, right? These are not things I actually want to do. So because I fear them, that's like a sign that these are not, it doesn't make me monstrous. These are not things I want to do. So that was like a huge moment for me. If I wanted to flag that, because I'm sure that's helpful to folks listening. And I think it might be good just to bring in some questions while we're on the topic. At 7:07, sorry, not 7:07. At 7:07, Elizabeth asks, are embarrassment and shame the same thing, especially in terms of moral scrupulosity?
I'd be happy to take a poke at that. One of the ways I conceptualize shame would put shame and embarrassment sort of within the same field, right? That embarrassment would be like a small shame, where it's still focused in on the self and an evaluation of the self, but it's kind of smaller. It's not quite as intense. And on the far end would be humiliation and mortification, which is a much more intense, if not traumatizing level of emotion. So I would say that embarrassment and shame, they're on a continuum. So shame would be the overarching term. Embarrassment and humiliation would be sort of the ends of that continuum, if that makes sense.
Yeah. For me, I think the interesting thing is that physiological reaction that you have when you feel embarrassed. And if you think about it, teenagers ride that as like the most fun thing ever, right? So if you, there are shows on TV that like just, completely anchor on that exact issue, which is let me embarrass myself the most I can, because it becomes funny, right? And so I think the difference is also the underlayer, shame, may have a different connotation than just a social connotation, right? Embarrassment is I done something wrong and it was perceived by someone else, and therefore I'm being judged and I feel bad about it. And those are both kind of very physiological. And we know that people with OCD feel sometimes more embarrassment. Like they notice what everybody's noticing. They think they're being noticed more than they are. So that increases the embarrassment and feeling, right?
And I also want to point out at 7:15, Barbara just mentioned something really crucial. Barbara said, the more I learn about my OCD, the less I feel shame. Knowing it is a brain disorder makes all the difference to me. I think that's really important because it helps us like be objective and more detached from our thoughts, because if you had cancer or lupus or the flu or COVID, you wouldn't be internalizing that as, oh, like what a shameful, embarrassing thing. It's far more destigmatized and accepted, right? But when you have a mental illness, it's like, oh, like that says something about my character. And it's not true. It's an illness. You didn't choose to have OCD. None of us did. Thank you, Barbara, for that. Go ahead, Jelani.
Actually, if I could add to that, I think going along with some other comments that other panelists made earlier. I think part of the difficulty too is again, like the way that people might conceptualize a thought and viewing a thought as if a thought is who we are, as opposed to seeing like a thought for what it is. Like a thought is, a product of, something, just a product of activity within our neurons, in the sense that we don't have this control that a lot of times, in the public, we're thought to believe that we have so much control in terms of our thinking. And so then like the stigma and the shame that one might experience from this public perception that, oh, if you have thoughts about, harming your own loved one or have thoughts about doing something sexually inappropriate, then that means that you are a bad person. And so often I've worked with clients who have come in just having this belief and being told that either by, from all other sources where, authority figures in their life, or even maybe from some other clinicians who just weren't very effective for them, unfortunately. And so that can be such a really, especially if it's something that was learned early on, it could be so ingrained, and having to take time to really, like you were saying, Vinay, to really be able to separate and having more of like this objective viewpoint and being able to see it as, okay, I notice that I'm having the thought, as opposed to saying like I am the thought. So being able to like defuse in a way, I like to look at things from a acceptance and commitment therapy perspective. So utilizing some of that cognitive diffusion to separate from that fusion to the thoughts, or to the belief that we are our thoughts, when that's just so not true.
Yeah, thank you. And I'm glad you gave some examples. I feel like it would be helpful for folks on the call, for us to drill down on what does this actually look like. So there are specific types of OCD that really lend themselves to shame. I have harm OCD, which I can talk about. There's also pedophilia OCD. There's postpartum OCD. It's like religious scrupulosity, sexual orientation OCD. If folks on listening to us aren't quite familiar with those types of OCD, do any one of you want to kind of maybe just give a quick summary of kind of what those terms mean?
Sure. So in the beginning, there were no terms. We had OCD. OCD was thoughts, any kind of thoughts, right? And then we realized that there were some kind of groupings that people had themes. And so over the time, and I'll give you guys a little context of like the history of those names, which was interesting, was that we start realizing that by baptizing, by naming them, we actually validated the people to realize, hey, this is the kind of OCD you have, right? So OCD comes in so many ways, so many, presentations. It's different, like panic disorder. If you have panic disorder, you have the same symptoms. Most people have the same symptoms, and they're very, very specific, and it happens in a certain way. In OCD, I think I probably know more OCD people than I know non-OCD people, and I've worked with thousands and supervised people that treat people and all that, and so you never see a person that is identical to the other. The presentation could be similar, but as you dig in, it's very different in the way it presents. And so, as research progressed, we realized that there were buckets that we could actually put some symptoms in that wouldn't allow folks to feel like, okay, right? So if you're having thoughts that you're going to harm a child sexually, or if you're going to be attracted to a child, or you're going to have pedophilia OCD, POCD, and if you are afraid that you're going to hurt someone, so you're going to go on a date, and if there's a pen, you're going to stab your date with this pen, it's harm OCD, right? So people can be afraid that they're going to harm others or harm to themselves as well, right? Scrupulosity is when we realize that a lot of people had this really right and wrong kind of concept that was so extreme. So even right now, let's say Mike start talking when Vinay was going to talk, and he felt, oh my God, maybe I cut Vinay off, and that is so wrong, and I'm not going to say anything in this again today, because what if I do this again, and that's so wrong. and scrupulosity could go in so many directions. It could go in the fact that I said, "Oh, hi, Jelani, how are you?" And I was like, "Oh my God, I can't believe I said that to him. I'm a married woman. I said hi to him. Was I, everything could get totally out of control in your mind, thinking that everything you could do could be wrong or perceived as something too forward, or so there are so many names now. Eventually it became confusing because there were so many types of OCD that we couldn't pick out, right? The idea is that OCD works like you can have pedophilia OCD or fear that this pen is going to stain your bed or your desk. Those are both OCD the same way, and one is not better than the other, worse than the other. Both are very complex, but because some of the content had things that are really scary, and that's why it sticks to your head. Those contents became considered more shameful until people realizes that it's just OCD is the same thing, right? It doesn't matter what you call it. It's actually a thought that you don't want to have, that is affecting you, and you're trying to do something to get rid of. And by doing that, you're going to have more and more of that.
I will say I was actually pretty furious at Mike when he cut me off. So, I mean, but just kidding. But
shame on you for saying hi to me. That was very inappropriate.
Exactly.
And yeah, I mean, I can speak to harm OCD. So I have lots of obsessions that horrible things are going to happen to my loved ones, which is bad enough. It's usually like external threats, like car accidents or, shooters or stuff like that. But the worst version of it is when I'm the threat, right? Like, what if I'm dangerous? How do I know I'm not going to hurt people like my family? I have like little nephews and a niece, like they're so vulnerable. What if I hurt them? What if I hurt someone on a date? Like Dr. Moritz said. And I feel like the reason that's so tied into shame, because it gets at like such a fundamental human question of, can I be trusted? Am I a good person? Like these are like huge, huge, weighty questions, right? That people with OCD have to ask themselves over and over and over and over again. Yeah, so it's a lot to deal with. And Mike and Jelani, I don't know if you wanted to chime in.
Well, the only thing I would say is that it's certainly my experience that people with more of the taboo themes of OCD, the pedophilia, the harm kinds of OCD, experience the greatest amount of shame. They're the least likely to report those kinds of obsessions. They're the least likely to seek treatment for it. They have possibly been shamed by other professionals in the past who have maybe reacted in an unhelpful way towards that, or family members or friends. So it's worth helping those people understand that as Dr. Moritz was mentioning, that OCD is OCD is OCD. However, certain ones make it much more commonly associated with shame, right? It's within our society to sort of look at someone who thought they could be a pedophile and think that's something we shouldn't be. That's not okay. And if you're too fused to that thought and say, I had that thought, I had that image, if I'm too fused to it, then it's going to provoke that innate core affect of shame, right? Because I just violated something that I don't want to be. My expectation of myself is that I'm not this. I didn't think I was this. And then I think to myself, could I be? And then you trigger that sort of innate shame that is common with all social creatures. And then it can get swung into the maladaptive part, which is where we start to attack ourselves for having that thought. We start to try to avoid things that might provoke that thought. We start doing other kinds of compulsions or escape behaviors to prove that thought isn't true. And that just fuels the cycle, right? And it fuels the secrecy, I think, because shame and secrecy seem to go very much hand in hand. And the more we keep it secret, the bigger the shame grows, and the less we're able to look at shame as something that we can change our relationship to. As Jelani had mentioned, from that ACT perspective, that diffusion, or as Vinay had mentioned, once you learn about like a harm OCD thought just being a product of OCD, it's not meaningful. That creates that separation for the person, and that healthy distance is like, this is just a thought provoked by OCD. This is not who I am, and now I can look at this experience and relate differently to it.
Yeah, on the, oh, sorry, go ahead, Jelani.
I was just going to say, I think that was a great explanation and statements in regard to like the cycle of shame. And, you know, and also just thinking about like the responses of shame and what you were getting into, Mike, a bit there about, you know, like the isolation and withdrawal and like the secrecy in relation to shame and how it can lead to so many problems when, you know, when one experiences this, the shame, which we can also look at in terms of like, you know, this strong, you know, self-critical self-evaluation, and leading to this isolation and feeling where it may not be good enough to be with others, or to may not just be good enough as a person, and may not be worthy, and may be evil, may be bad, so on and so forth. And you know, another common response could be just trying to like rid of this feeling, whether doing so by then leading to like the compulsion. It's like, I don't like this feeling. I don't like this thought of why did I have this thought? I need to get rid of this, or I need to get rid of this image. It can't be a part of me. This is because I don't want it to seem like this is a part of me. I don't want to accept it as part of my experience. And so like trying to make those efforts to get rid of it, and then where we get into the compulsion, where it be like some sort of, say, like a neutralizing mental compulsion, and like, let's replace this negative with a positive thought or a positive image, or let's let me like do some repetition or do something like backwards, and like going back to when I was doing something that was good and before I felt like this negative, this obsession, and whatnot. And so, but then the problem with it engaging in those compulsions is that it may like have some like temporary alleviation of the distress or the experience of the obsession. But as we know, like this doesn't work long term, and that person ends up having to do this repeatedly and repetitive over time. And this just gets stronger and stronger the more that one continues to engage in those compulsions.
Right. One thing that we could talk about when it comes to the secret, OCD was before considered a secret disorder before the shame disorder. And so long ago, people did not know about OCD at all. They actually thought that a lot of our patients had a thought disorder, that they were schizophrenic, that they didn't know right from wrong, and that even though, how could you have those thoughts and not be psychotic? And it was very sad, because the reality was that it wasn't a thought disorder like that, and it created even more stigma, because it made people feel that they could be dangerous, right? So thoughts could be actions, and they could be dangerous. And so a lot of movements in terms of psychology, when you say like, if you think positively, positive thinking creates positive outcome, reinforce a lot the feeling that your thoughts actually create changes in action, and it made it for a very hard position for us as OCD clinicians, because as some people are talking on the chat, sometimes we're not very popular, because people don't understand OCD. They don't understand what we do, and so I can't tell you how many times people would say we're mean, we're doing this wrong and that wrong, and so I do believe that a piece of the secret also is because people sometimes didn't realize was OCD. Like, now that we hear so much about OCD, very young kids get diagnosed with OCD, much different than before. I mean, you wouldn't see a 4-year-old, a 5-year-old coming to the office and the parents saying, I think this kid has OCD. You wouldn't see that. And nowadays you see that very often. And this is, to me, thanks to the foundation, which really ran the past few years, 20, 30 years, an incredible campaign for awareness, right? People really had never heard of OCD. OCD is in the common language, maybe a little too much for sure. And people using the way they're using is not right. But the pendulum was so far to the other side, where so many times I would say I'm an OCD expert, and people had no idea what OCD was. No idea. Other psychologists had never heard about OCD before, right? So I'm going to say that we are enjoying a moment right now where it's unless you're living under the rock, no one's never heard of the word OCD, it became a word, actually, not obsessive compulsive disorder. Very rarely now I have to say, I treat people that have thoughts and they have to do actions. I don't have to say that anymore. And I tell you, that's the way it was before. So I have a feeling that people kept it a secret and had all the shame and embarrassment and all that because also they didn't understand what that was. They thought they were going crazy. They thought they were losing their minds, right? And they didn't realize they had a neurobiological condition that affected the way they felt, the way they thought, the way they move, affected a lot about them that they didn't realize. And I think that's what is so exciting to be able to talk about stigma now, because we have a much, much bigger opportunity for impact than we ever had before.
Thank you. And I want to bring in some audience questions here because we just got a string of them and some of them are really great. And Jelani, you talked a bit about folks like leaning away from these intrusive thoughts and that making them worse. And at 7:23, Madeline said, have had OCD for 70 years and just now finding ways to deal with it. Do you think that repression of thoughts creates you to think it anyway? I think we did touch on that a bit, that like a big point in my treatment was realizing when these violent thoughts come in, if I try to fight them off, like if I try to go to war with them, they get stronger and stronger and stronger. Just like if you tell someone, don't think of elephants, they immediately start thinking of elephants, right? Right. And there's a couple of other comments kind of on the same subject. Marissa at 7:27 asked about kind of what you should do about that. And I think a few other folks did. So instead of fighting it off, again, disclaimer, this is not official therapy, but what is the general approach to having those intrusive thoughts in case folks are not familiar?
Yeah, so really good questions. And so in terms of like, how do we treat these thoughts when they pop in your head? I think one of the important things to take into consideration at the very beginning is, I'm not sure if we touched on it already, but, intrusive thoughts are experience that, majority of people have, whether you have OCD or not. It's, people often don't realize it, that the people without OCD have these thoughts as well. And if anything, I would argue that everybody has these thoughts, and people who say that they don't, either like you don't recognize it, or you're not very self-aware, or you're just lying. But these are such common thoughts that we have, whether it be like if you're, standing over, like you're walking over a bridge and you're looking over, the thought comes in like, what if you jumped? Or, the thought of, I've even, one intrusive thought that I know that sticks in my head a lot. I'm going to put myself out here, like maybe there's going to be some shame attached to it, but who knows? But intrusive thought that sticks in my head was when my sister and I were younger, we were sitting on the edge of a dock and there was some huge barracuda in the water below. And the thought came in like, what if I pushed her? And it's like immediately I started backing away, like, whoa, what is that? But then I didn't take too much to it and was able to like dismiss it. And, it didn't like avoid water or avoid my sister as if I thought it was going to hurt her, because, I don't have OCD, but someone with OCD might view this as, again, like attaching a lot of meaning is like, what does this mean about me and would I really do this? And so, again, being able to recognize that these are thoughts that we all have to some extent, but the difference between someone with OCD and someone who doesn't is that, again, with someone with OCD is going to be attaching some meaning to it and trying to figure it out, which then ends up getting in this struggle. As opposed to like someone without OCD is just going to dismiss it like, oh, that's bizarre, that was weird, whatever, or maybe not even really notice it, not even paying attention to it, and just being able to let it go, not identifying it as like some part of their identity. And so, so once being able to have some of that recognition that like this is a common experience, and like being able to allow for some space. I mean, there's a lot of different ways that one can approach this, whether we're looking at it from an exposure therapy approach and being able to, allow oneself to be able to have the thoughts more and like being exposed to the thoughts more instead of the experience of pushing away from it, and getting used to having that experience and having the subsequent anxiety and other feelings that may come with it. There could be also the approach of being able to look at, challenging this in terms of like, all right, we put ourselves in doing an in vivo exposure and being able to see like if I have the thought that I'm going to hurt some children if I'm around them, what if I went to a park? and let's see, like, am I really going to hurt a child? Or like the exposure that one can do with a therapist, like I've done with clients, is like give them a knife, if they have some harm obsession and believing that they're going to harm me. It's like, of course, I assess for any like psychosis or anything else to be on the safe side. But, if we're talking about just pure OCD here, OCD and, nothing else if we're talking about OCD here, then it's a situation in which I feel completely safe and like being able to hand somebody a knife and say like, all right, put the knife to my wrist, to my neck and whatnot, and challenge that thought, and seeing that just because you have the thought that you're going to hurt me doesn't mean that you will do it. And so being able to build up that experience and that confidence and that knowledge, and seeing like just because you have the thought, it doesn't mean anything. So doing that, there's some exposure. I mean, there's more that I can talk about. We could talk about it from an ACT perspective. Some of the things that we mentioned already earlier, and just like being able to create some space for these thoughts and not viewing them as not giving them any meaning. I think we can also look at how these thoughts or the shame prevent us from being able to, or prevent a person from being able to live the life that they want, living the life that matters to them, or pursuing things that matter to them, I should say. So if a person is talking about postpartum OCD and having thoughts that one might hurt their child. So if they find themselves like then backing away from taking care or interacting or being involved with one's child, then we want them to make make movements toward what is important to them. And if they see themselves as a loving parent and identify as that and caring parent, then all right, let's make movements toward and steps toward doing that, which is going to involve taking care of your child, being in contact with your child, as opposed to pulling away from your child. So a variety of different ways. I kind of just gave like little bits of that here and there, and we could probably can expand on those a whole lot more. But those are some like the general approaches that I know that I am familiar with and that I utilize, and I know to be effective.
So for me, I talked a lot about the sticky brain, right? So for me, people with OCD do have a difference in the way the information seems to process and stay there, right? And maybe they entertain them more because it sticks there more, right? And so when you have something that is not leaving, you turn to it and pay attention to it. And, so if we look at the mechanisms of thinking, the loop that is created is something important to be aware of, and it really is very helpful to realize that you're going to have the tendency to feel that there's no space between thought and action. It is part of this thought and action fusion, but sometimes people who are not even fused, they don't think that there is a space and a sequence of events that happen, right? So if my OCD tells me I'm going to jump from this building right now, I literally have to stand up step by step by step. I have to get to the edge. I have to go. That whole process of doing that is gone. It's just like I'm thinking, boom, I'm down there, right? So it's like I wish that was the case for cooking dinner. If I think I'm hungry, boom, dinner shows up on my plate. I think that would be fascinating. I would love that. But it's very common that a person with OCD would say that's not possible. If you think you get dinner, if you want dinner, dinner doesn't show up on your plate. I said, what do you have to do? Well, we have to cook and buy and everything. I was like, the same thing here, right? We have a lot of steps that we need to take, and all of a sudden you got that in a magic thinking way. But I think the most important thing is that thoughts, when they are weird, they may create discomfort. And maybe someone who doesn't have OCD may have a very quick flare of discomfort. And then the thought kind of like brushes off. But if your thought gets stuck in your head, it starts to really hurt you, right? And then you start to try to manage this in the wrong way because nobody told you that you have a sticky brain. You didn't realize that the thought is going to come in and get stuck. And your job is going to be to not do anything about it, to not try to fix it, to actually make fun of it if you can, right? Start to respond to the brain like if it's trying to bully into making you scared. right? So the feeling of fear in OCD is actually measured, right? And it is the same fear that we get when a gun is to your head or when you see an accident and your stomach drops. So if you have to avoid that sensation, you're going to do anything in your power to stop that feeling. If your thoughts give you that feeling of your drop on your stomach when you see an emergency, or if someone gets a gun to your head and you hear to your head, you're gonna do something. And so teaching that skill that you have to deal with that discomfort, it's actually the skill that is the most precious that we could give people, which is if they're able to realize your brain is tricking you, you're gonna feel uncomfortable, but that is gonna change. It empowers people to actually work on the thoughts.
Yeah, and I can give some concrete examples as a patient with harm OCD. Like as I said earlier, when I was younger and I wasn't, fluent on these things, when these violent thoughts would come in, I would fight them off and say, I would tighten up, I would self-medicate, I would just try to get rid of them, and they would just get stronger and stronger. And now my exposure practice is I will write out scripts of just horribly violent things happening to people I care about, and I will read them over and over again. I'll play them into my phone and listen to them over and over again. And eventually your mind is like, oh, these are just words and sounds, right? These are not threats. And like now it's like when that thought comes in, like the thought that I might hurt someone is not inherently any more meaningful than the thought I want like a hamburger right now, right? If anything, I'm far more likely to act on getting that hamburger, right? So like that's actually much more meaningful, right? The trivial one is the first one, right? The hamburger is important. So that's important to think about. And then also a metaphor that I like is that people often think of this as like a war, right? Between good thoughts and bad thoughts, like pieces on a chessboard, and you want to be like one side. And that's not how you should think about it, right? A better way to think about it is like being the board, which envelops everything, like light thoughts, dark thoughts, complicated thoughts, violent thoughts. It's all you, and they're all inherently meaningless until you act on them. So like reframing it as like taking a step back and being the board has been helpful to me.
Yeah.
I want to bring in another question from Ellery at 725. Just in terms of highlighting the stakes of what we're talking about here, Ellery said, I recently disclosed to a trauma therapist about my pedophilic OCD, and she had little understanding of the condition. So damaging, left me feeling suicidal. First of all, Ellery, I'm sorry you're dealing with that, and I hope you consult some of those resources that we shared if you're still in need. But yeah, those are the stakes here, right? Like sometimes people think about stigma as just like being nice to people, but that's not what we're talking about. We're like stigma directly affects mental health outcomes in terms of opting people into more care, in terms of people getting the right care. So I think we should talk about that a bit. If from clinicians' point of view, if you can talk about how decreasing shame actually like helps people heal.
Yeah, and Ellie, I'm really sorry to hear that. I can't tell you how many times we get consulted by programs, wilderness programs, regular programs, therapeutic boarding schools and everything, that they have a kid with OCD and they are completely freaked out over the thoughts, right? And they don't know what to do with it and how to manage. And it's not uncommon to have that, right? And so educating clinicians is really something that is our mission, and it's the mission of the foundation, right? So other clinicians that don't work with OCD are able to realize, what OCD is all about. And OCD is scary because there are some ethical rules, mandates that we as healthcare providers have to follow. So if someone tells us that they are going to harm a child, we have to, report. If they say they're going to harm themselves, we have to report. And the fact that there's no any kind of mention in the law that if it is from OCD, it's okay. So it's funny, in like probably 2010, we presented at the World Conference on trying to find some ethical support for the clinicians that work with OCD. Just remember, now people know about exposure response prevention. The first time I mentioned at a conference in Florida, exposure response prevention, the APA attorney thought that I was going to lose my license if I did exposure therapy. He said, that is against the law. And I said to him, I have articles and articles to show you that this is the treatment for OCD, right? So that's the sad thing for you guys to see how much, we've walked the ground. But what happened with Ellery is not very uncommon still, where people don't understand the difference between a symptom of OCD and someone who's actually, struggling with certain conditions. And the fear of the condition is not the condition itself, right? So that is and if your therapist hurt, the kind of exposures we do, then you will really hear a dissatisfaction, right? Because then you'll see that they truly don't understand the therapy and the concepts of the treatment of OCD.
Yeah, I'll jump in on that one. Absolutely. I think this is what organizations like IOCDF have been doing a great job at the last 30 years is spreading this message so that healthcare practitioners, lay people outside of the treatment specialists understand what OCD is and is not. And maybe we can learn to ask better questions, right? Like if you're a therapist, maybe we can learn to ask better questions. If someone says, I'm having these kinds of thoughts, instead of jumping to the assumption that these thoughts are meaningful and need exploration, or it means you're dangerous, or we should contract for safety or something like that, explore a little bit. Like, we know OCD can sometimes present with these thoughts. Maybe we should do some more assessments, right? And I think part of dealing with shame is this coming out of the self-compassion literature, right? The common humanity piece here. If we as a specialist organization and healthcare practitioners at large can do a much better job at creating a space of common humanity by being better educated, better informed, then when a client or a patient presents with a particular issue, the first thought or the first words coming out of their mouth isn't something that might feel shaming or scary to the person, but a little bit more like, oh, okay, well, sometimes people have those thoughts, right? Let's take a look at that. And maybe it's OCD, maybe it's not. But I think far too often the case is that kind of OCD thought is still not widely understood outside of our specialist community. People understand contamination OCD just fine, but taboo themes of OCD are still rarely talked about within the general therapist community, let alone healthcare practitioners at large. So I think there's a lot more work to do there.
Definitely, I would agree with all of those comments and all what's been said so far. And I think what's even more difficult or more what's also problematic when it comes to shame is that it can lead, like the shame that one might experience from having these thoughts can lead them to not wanting to share it, even when they are meeting with a clinician, who may be even like OCD specialized. And so, so to your point, Mike, with some of the things that you're saying, it's even for us who are within this specialty, being able to make sure that we are helping clients to feel comfortable and welcome and trusting of us, and that we're not going to shame them and judge them for the thoughts and intrusions that they're experiencing, and being able to help them like normalize it in a sense of being able to show them like, yeah, that's common. This is, yeah, I'm not going to judge you any differently because if you have these sort of thoughts, like this is quite common, this is treatable. Because when someone hides these, keeps these types of experiences secret, then this just becomes a barrier to treatment and can lead to a person not being able to have the success and the progress, make the progress that they're hoping for in treatment when one's holding things back because they are too ashamed to express it, to talk about it.
And I think this is important in a treatment, that as soon as treatment starts, is understanding the difference between, the identification of the person with the condition, right? So there's OCD and there's you. If you don't identify with OCD anymore, it doesn't matter what OCD tells you. You could talk about, sex with, alligators. It could talk to you about killing someone. It could talk about taking the eyeballs. Vinay's eyeballs look really good right now. I was just going to dig them out with a spoon, right? They could say anything. OCD could say whatever. It doesn't matter, right? So once we actually realize, when I wrote the pediatric book called Bling 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 Clop Clop, I created a character called the OC Flea, and the OC Flea was supposed to be the bad guy in the whole thing, because OC Flea was giving people the thoughts and the feelings and convincing the animals in the farm to do all this OCD stuff, and the idea is if you are not telling about the symptoms, you are protecting the OC flea. You are protecting, the part of your brain that is not working and helping you. And that part is not you. It's a part of your brain that has a function that is not working the way we want it. It's a glitch, tiny glitch. But one good thing is the rest of your brain is good. So the little glitch is there, but the rest of the brain is good. So which part are we gonna, use to win? So the rest of the brain has to say, hey, let me tell on the little guy there, right? So I always tell the little kids, like, what does a bully say to you? The first thing a bully say to you about their behavior is don't tell, right? So because if you do tell, the bully is going to get in trouble and the bullying is going to have to eventually end. So OCD has the same game where if you keep it a secret, and OCD tells you to keep it a secret, because if you tell, something bad could happen or your thoughts could come true, or because people are not going to understand. Number one is it's going to reinforce the whole OCD process, but it is that lack of understanding that you and your OCD are not the same thing. And I'm going to see in my lifetime the cure that people are going to get better and it's going to be over. And I'm going to take the longest vacation ever and it's going to be amazing. But OCD is a condition that teaches so much about not only the brain and ourselves, but about resiliency, doing better. I've treated kids 5, 4, 3, every age you can imagine. And then I see them, they bring their kids to meet us. You watch them go to medical school. Some of them are my favorite colleagues ever now. It is the most amazing thing to see what people with OCD, like Vinay here, right? Ethan, like those people are incredible people. And so, taking OCD as like, hey, this could teach me so much about life and myself. Like Vinay could fight his own brain. Do you think he'll be upset about fighting someone that wrote something he didn't like? Like, if you can fight your own brain, you're powerful. You could do a lot if you can fight your own condition, right?
Thank you. Yeah, thank you, all of you. Before we pivot away from just this idea of like clinicians needing to be like, retrained and being competent on not stigmatizing folks, another factor that we should raise is that this is very different for people of color, right? Like what's shameful in the South Asian community that I face is different than what's shameful in the Black community, is different what's shameful in the East Asian community. And we need to train, we need cultural competency for our clinicians also, right? I distinctly remember a time I had a therapist who is just like, yeah, why don't you just call up your parents, let's bring them in on a call, let's talk to them about all these things so they, and I'm like, no, I'm not doing, like, we don't talk about these things, and then it became like a weakness for me, like I wasn't trying hard enough in my treatment, which made me less wanting to participate. And I'm like, no, I'm trying very hard to get well, but like, this is just not a thing we do, so like having people understand that is hugely important. I think we had a question I wanted to raise. So Lana at 750 raises another aspect of the stakes here. Sometimes I think if I were locked away for the rest of my life, either in an institution or even in prison, the OCD would disappear. You can't add harm to loved ones if it's like you've died. Sorry again, Lana, that you're struggling with that. I hope this talk is helpful. But that's an urge lots of us have, right? Especially me with harm OCD. It's like, well, I can just hide away from the world, right? If I never go out, if I say no to all the party invites, if I don't go babysit my nephews, then I can't hurt anyone. And I think it would be great, like if you can nudge everyone in the chat to not do that as 3 clinicians, to like, how can we escape that and kind of move towards what we value and live our lives? I'm sure that comes up with your patients all the time. Like, what do you tell them?
Yeah, I think, yeah, as you stated, like it may feel as though the best response to these experiences, to the obsessions, would be to, well, let me make sure that everybody else is safe, or so that I don't hurt anybody or hurt anything, because that's very important to, that's what's very important to a person, like not wanting to hurt others. And I think one thing, I don't know if we stated this already, but But I don't think it's something that a lot of people know, but as clinicians are quite well aware that like people with OCD are far less likely to engage in these types of, say, like deviant behaviors or whatnot than a person without OCD. I mean, the fact that when somebody is so distressed by something of this order of these thoughts is an indication of how much how important the matter is to that person. And so, if feeling so distressed by the thought of like hurting someone else, it's a sign that this is something that you absolutely don't want to do. Now, we don't want to use that as a gauge to say like, oh, like if I'm no longer distressed by this in the future, does this mean that now I want to do this? Like, no. We want to be able to work on, again, being able to making space for these thoughts that we can't control. We cannot control whether or not one has these thoughts. But we can, and the problem isn't the thoughts or the images, these intrusions themselves. But the problem is the response to them. And so if one were to respond, to the thoughts of harming somebody by like confessing or wanting to lock themselves up or avoiding, then what kind of life are you really going to be living? And I know like when in this situation, it may feel as though like there isn't going to be an alternative. Like you can't live with these experiences. Like how can one live with having these thoughts, especially when you view them as so dangerous, so threatening, so different from who you are and who you want to be. But a person can live with these experiences. And so instead of trying to live a life without obsessions and in terms of without these, unwanted images, thoughts, and internal experiences and whatnot, like learning to be able to have a life while those things may be part of your existence is going to lead to much more fulfilling, much more meaningful life instead of, say, like trying to avoid, trying to escape, or living, being in prison for something that one didn't do.
I've often suggested to clients, I don't know if it would be helpful, but piggybacking off of what Jelani was saying is OCD is frequently sort of a what if situation, right? So what if this happens? Could this happen? Maybe this would happen. And the more stuck the thought is, as Dr. Katia was talking about, the more stuck it is, the more we pay attention to it, the more scared of it we get, and the more real it feels. But it's still a what if situation at the get-go, right? It's a thing that maybe it's happening. Could it happen? Could this be? And if we respond into a what if situation by sort of locking ourselves away, isolating ourselves from society, we're taking a what if situation and we're thinking we're doing something good, but we're actually creating a very real problem, right? So isolating yourself is actually creating a very real problem as a response to a what if problem. And having that distinction for people, I think, is critical, and we as therapists to remind folks of that OCD is about that what if, that uncertainty, that doubt proposition. And our responses to it accidentally, unbeknownst to us at the time, can actually create bigger problems, real time problems. And to point that out and say, maybe, as Jelani was saying, maybe what we need to do is we need to slow down, step back. Maybe we can get connected with a therapist that can help us better understand our relationship to those obsessions, its context in the disorder itself, and a community of people, sufferers like the IOCDF has and various other advocacy organizations that have been through this before, that can say, yes, I understand where you are, and can provide that support and that compassion for those people, because running away from that thought's only going to increase your attention towards it and make you more afraid of it.
Yeah, and then it's going to validate that OCD is telling you the truth, right? So this condition that is trying to trick you, the bully that is trying to tell you stuff to take over your life, then you reinforce it as telling the truth. We're saying like, you're negotiating with a terrorist, because I have to tell you right now, you could avoid everything and that's never going to be enough, right? So I love to tell the story of a patient for many years ago, where this person, built a whole section a bridge to get to another side of a house that was completely decontaminated, and there was nobody that could go in there. And so the family thought they kind of solved the problem because this person would have been happy. And OCD is never enough. So the more you do, the more you have to do. All of a sudden, the OCD said, oh, what if you black out and you didn't realize you went to the other side and came back? So she had to sign on her name every 2 minutes because that's how long it took to go back and forth, right? So, and it went from there to more and more and more. So the idea that there was a way to negotiate with OCD, I'll give you a little and you're gonna let me live, or I'm gonna save people and I'm gonna be okay, unfortunately doesn't happen. And so OCD is a progressive condition. Unless you address it, it's just gonna get worse and worse and worse, and it's never gonna suffice. So there's no way that you're going to make OCD happy. You give, you're going to need to give more, and so, in a way, and I'm not comparing the two things as equal, but it's someone who say, I'm just going to use a little heroin. I'll take a little heroin and forever, I'm just going to take a little bit of heroin, and it's not going to work because that's not how the body works, right? And OCD does not work that way. It doesn't suffice. It doesn't work when you just say, okay, I'm just going to take this part and then I'll make things better. Unfortunately, it doesn't get better. It goes all over the place.
Yeah, absolutely. And Jelani, I love that you mentioned that like folks with OCD are generally like the most kind, considerate, harmless people in the world, right? And like that's why we're so afflicted by this. Because like I grew up thinking like a monster, like what kind of person obsesses about these violent things? But all of us, like having OCD, that's a sign that like we care too much, right? And like we love too much. So like letting people down is like awful to us. It's like the worst thing in the world. So that's not a sign of something monstrous in you. That's a sign of something very gentle in you, right? So there's no need for additional shame for that. Yeah, I just wanted to raise
right.
that.
And Vinay, sometimes, for some folks who have comorbid conditions, they have both an impulsive and compulsive behavior. And so they may be very nervous about something and very protective. And then they go ahead and engage in behaviors that they don't want to engage in. They're not good. So for instance, they may be scared of getting a cold, but then they go and engage in situations that are actually risky because they have both impulsive and compulsive aspects to their condition. And so for those folks, sometimes when they hear, oh, you're never going to do anything, then they say, but I actually went out with this guy and I didn't think about it, and I didn't even plan, but at the same time I'm very careful with other things. So just I think that acceptance of whatever the brain is trying to figure it out, and that we have the power to change both sides, right? That we change the impulsive part of the brain and the compulsive part of the brain is also important, because those people have a lot of shame. So when you have a comorbid condition, you actually experience a lot more shame because you think that, you could, maybe you're not a good person for real, because not only you worry about this, but you've done this and that you're embarrassed that you actually did, right? So they mix everything up and it becomes very, very difficult.
Yeah, absolutely. I'm going to bring in a question from Brian in a second, but I also just wanted to address one more part about Lana's question in terms of hiding away from the world, which you all like expertly talked about, the need to move towards things. I feel like growing up with OCD, your first thought is always like, I just want all the thoughts to disappear, like all these fears to go away. Like my dream is to be fearless, and that's impossible, right? Like no one's fearless. Like these thoughts are never going away. So since I'm a writer, I like to think of it, as like metaphors. So I feel like I think of it as like you don't want to be fearless, you want to be brave, right? And those are two distinct things. So like if you're not afraid of a forest and then you walk into the forest, that's a really boring story, right? Like no one needs to hear any more about that. That's not going to be a movie. But if you're terrified of the forest, if it like haunts you at night, if it keeps you up at night, and then you walk into the forest, well, that's brave, right? And that's like a story worth telling. And like everyone managing their OCD, doing exposure therapies, facing their fears, are like walking into that forest every day, right? And like clinicians like you and like organizers like me, like we can give them the tools to do that, because that forest is not going away. It's going to be there for the rest of your lives. But you can get through it, like if you're equipped to get through it, and you can get to whatever the hell is on the other side, like whatever you value, right? So Lana, I would urge you, to do that. You can definitely get to the other side, like with the tools that we're presenting you. But at 7:52, just to pivot a bit, Brian said, I feel that destigmatizing OCD involves destigmatizing a lot of social taboos, moving away from criminalization, moving towards harm reduction and prevention, which is not something we've addressed at all yet. If any of you wanted to talk about how, like, yeah, it's just the fact that so much of America's approach to mental illness is criminalization. When people call 911 for overdoses or for mental health crises, it's often police who are responding and often gets worse. Lots of conversations happening about that right now. Also, every time there's a mass shooting, right, the media is like, well, was the shooter mentally ill? You know, what's their history? Are they dangerous? In movies, you know, television shows, like, we're often depicted as threats just by being mentally ill. Yeah, so how does that factor in? Is that something you take into account in your treatment? How do we change that? Kind of a big question, but any thoughts on that?
I think that.
Yeah, go ahead, Jen.
I was just going to say, I think it's a great question, and it's a difficult one to approach. I feel like it's something that almost it requires a big, like a broad approach, and I mean, definitely we can all do things individually and with clients or whatnot to approach this, but it also has to be done on a bigger stage and a bigger level. And I think it's a big part of what this foundation does, and just being able to have this type of conversation and being able to spread the awareness of OCD and shame and stigma and whatnot, and being able to help people have more better awareness, better knowledge about what OCD really is, and not seeing, viewing like intrusive thoughts and whatnot as these experiences that mean something, that make, you know, put a label on someone as being horrible or bad or evil or whatnot. So it's something that I think takes a lot of action from us as a community to be able to continue spreading this awareness, and again, individually we can do our parts and be able to spread more of this awareness too. But it's a great point, a great question. That definitely, I think, contributes to this being a problem in terms of the criminalization and stigma of OCD and other mental illnesses.
And I think it comes from that volition conversation that we started too, you know, where, you know, you are in control of your condition. And if you're not in control of your thoughts, then you could be a dangerous person, which is no correlation at all, because none of us are in control of our thoughts. They are involuntary. They come to us. We don't control our feelings either. We may feel angry. I may be really angry at Mike right now, but that's okay. You know, yeah, maybe I am, maybe I'm not, you know, but it is what it is, right? Because no, we control the feelings. I don't know why, but we actually, as a community and a world, and, you know, I'm very interested in the international community. I do a lot of work in Latin America. And if you guys think that this is bad, I want you to see what goes on in Latin America. So imagine the underprivileged, like imagine going to a slum in Brazil and talking about obsessions, right? Or even any other condition related to OCD, and the people treating that population. So just remember that there are so many aspects, and even in terms of treatment. So, you know, people mentioning that their therapists don't know anything about OCD. You know, if you go to a hospital and you get into the emergency room and they don't know anything about, you know, a heart attack, they're going to be in big trouble. And there are no other, there's no like, I'll do whatever I want for your heart attack. So I'm going to have you do some deep breathing, eye movement. I'm going to do this and that. There's a protocol that if you don't follow that protocol, if you don't give that person certain medicines at a certain standard, you're going to lose your license to practice, right? And what's so upsetting to me is that, you know, that's not true for mental health. And so if someone goes to a psychologist or a therapist or a counselor or a nurse practitioner, and that person never heard of OCD, and they decided to treat them in whatever way they want. Let's say they decide to draw with Sharpies on their hand and say, pay attention to the Sharpie, pay attention to the Sharpie. That's treatment in their mind. And they are not going to lose their license for that right there, because they could justify that there was, like, you know, some type of work. So to me, in the global phenomena, is not only about the discrimination and stigma of the people suffering, but also what are we doing about treatment, right? How is it okay for someone to go and share with their therapist that they have, POCD, and that be the most traumatic thing that happened to them? That's unacceptable. This is not the 1920s, right? I mean, there's 11,000 papers published in the world of OCD. Have you ever looked at one? Look at one, and you'll see like, oh, that sounds like OCD, right? Maybe, I don't know. Let me call someone and consult. And that's the sad thing for me, is that, in terms of treatment, and remember, and Vinay could say from his background, Jelani could say, Mike, I don't know your background, but like from my background as a Latin woman, wow. I mean, it is very sad and very distant in terms of reality of treatment.
And to the great points that you guys are making, and that's given me a lot to think about myself. I see that one question so big and difficult to even approach and answer. It's like, I don't know. I think there's like this long game that we have to play, right? There's got to be some accepted education of the young people, and I think that's probably occurring, but like, how difficult would it be to institute health class teachings about common psychiatric conditions and common presentations, starting in third grade, maybe younger, and destigmatizing from there, creating a systemic and an educational and a social understanding that may take 15 or 20 years to make a difference, but then those people become therapists and doctors and politicians, and we start to really, which I hate to say having to wait that long, but it seems like changing current minds is very difficult. As Dr. Moritz was saying, like, there are plenty of people out there practicing treatment of OCD with things that aren't known to actually treat OCD. And how do we shift that paradigm? And I think it's going to start, from an educational standpoint, much younger, from a social shift over time. I think, to me, that's a realistic way that this changes in a meaningful way.
And I think also what's beautiful, like, that is happening is, I remember many years ago in the I'm on the scientific advisory board for the IOCDF, and we are talking in a meeting about bringing in some celebrities, some people that had OCD and wanted to share with the world, right? And we couldn't figure anyone out. Like, there was no one willing to talk, right? There was no one willing to come and share that they had OCD. And as you could see, there is a shift in that world right now, where public figures are talking about, Howard Mandel for the first time. He's been talking about his OCD for a while, and he's been talking about the difficulty for him to get into treatment and do the treatment. And now, this interesting part where he's talking about, like, it caught up with him. Right now, it grew and it's bigger and it's so pervasive, right? And so that is, to me, one of the biggest changes in stigma, is that people who are in the public eye decided to say, I do have this, and it's okay to talk about it openly. And it's no longer, something that I need to keep it a secret. And I think that that's really beautiful and important.
I think if I can add to that, all of the points that y'all are making, and kind of goes to the, a question of, like, how do we kind of deal with shame too, in a way of, like, that's productive and healthy and helpful, and kind of with what you're saying, Dr. Moritz, is being able to, like, shed light on shame, and in the sense that, to what Mike was saying earlier, and how, like, the secrecy that's so much involved with this, and that with the secrecy, that shame and dysfunction just continues to grow. And so now I wouldn't say that it's necessary for everybody then go and tell everybody about, all of your problems and all your obsessions and compulsions and whatnot, because not everybody will be receptive and understanding, of course. But the more that one is able to find themselves being vulnerable and opening up to those that they trust, and those that that they feel safe with, the more that shame starts to break down, instead of feeling that you are a bad person and that, or feeling that you are doing bad things and feeling guilty and whatnot, and being able to change your relationship to your experiences. And especially if you're able to, I know I've had clients at times when they finally open up to, like, say, their parents or some other loved ones, that they have these thoughts like, oh, I had thoughts that I wanted to hurt you. And they're like, okay, whatever. Like, I know who you are. Like that doesn't bother me. It's like, instead of before, they might have been thinking that, oh my God, my spouse is going to divorce me, or my parents are going to disown me, if they knew that I have these types of thoughts. But then once they're able to actually open up and reveal, oftentimes it's more like, it's like, oh, I feel so much better being able to let that off my chest and shed some light on this. Now,
right. And a lot of those parents participate in treatment later on. It's funny to watch them, right? Talking about exposures and doing exposures when the kid felt like, oh my God, my mom will kill me, my dad will kill me. And all of a sudden they are fully immersed on, oh yeah, you are. Yes, you are. You're going to kill everyone. Yeah, that's awesome. I always wanted to raise a child to kill people. I'm so proud of you. And it's so cute to see the parents, because they get into it and they feel like, okay, let's do this, right? But important, what Vinay said also is, treating people within their cultural, and upbringing, and understanding the differences. Like, so doing exposures with some parents here in the US is very different than if I told a parent of a 10-year-old to say to the kid, yeah, if you die is great. We have too many kids anyway. Say to a kid in Latin America, say to a parent that in Latin America, and they literally want to, like, then it's harm coming to you for sure, not even harm OCD. They're going to harm you, because they would say, like, how would you do that? That is, and so the steps to do that with them is very different, the same way as the steps to talk about mental illness or symptoms that are so hard to understand. It is interesting to do when people come from different cultural backgrounds.
Can I quickly piggyback off of something that Jelani had said that I really liked? It was, I'm forgetting the exact thread of what you had said, but so like shining light on the secrecy, shining light on the shame, and sort of diffusing it. There's an old saying from AA, which is, "We're only as sick as our secrets." And I think that's an incredibly helpful way of wrapping our heads around this. And it's not just sort of OCD, it's shame in general. It's like, we're as sick as we hide this stuff from people. And there is a discretion, like you mentioned, about who we share with and when we share. And I think you can work through that with a therapist about what makes the most sense, or find a community of people, which I think, again, the IOCDF and other advocacy communities can contribute with. But if we just sort of speak it out loud and then realize that what we're getting back is like, yeah, join the club, right? And then suddenly that just washes away. And it's something that it's nice to try to give it to yourself, right? But it's so much more powerful when it's coming from other people, complete strangers even, who are just like, oh yeah, totally had that thought. Have you ever had this one? Right? And it just kind of washes it away. So again, that secrecy, if we can get people to look at OCD in a general sense, that this isn't something we need to be secretive about. It's not something we need to be ashamed or kept hidden. We can keep it private. Not everyone needs to know. We don't need to wear a sandwich board on the middle of the Times Square saying all of our intrusive thoughts. But we can, in fact, move from a sense of secrecy to privacy and change our complete relationship to it.
Right, because I think many times that become a compulsion also, right? You want to confess all your thoughts and everything that you have, and becomes that need to tell. But I don't know. I'm just thinking, we're talking a lot about shame and secrecy. It's funny. I think in clinical work, like in the day, we work in the most severe cases every day, right? So residential and intensive, and people who are so severe. It's funny how shame does not really seem to, kind of in that environment, we let go very quickly of the shame. And when the families come in, we let go. When OCD gets so bad that it really stops people from living, all of a sudden it becomes such a crisis, right? That we realize that we have to let go, and you can't be as sick as your secrets, because your secrets have to come out. You have to talk about it. And it's funny that because I was thinking, as you guys are talking about shame, how at a certain level, and I hope that people don't get to that level ever. That's why you work hard on it and work always and get proper treatment. So you never have to get to that level of very, very severe debilitating OCD, because when he gets there, it is just so beyond that concept is just like, and so I think that usually when people understand OCD, the shame about having or what OCD is about almost separate from them, and it really creates their own kind of person, right? They just feel different about it. So that's just been my experience with the work with the very severe and very complex cases.
Yeah, thanks all of you for all those tips. I think maybe we can take one more question and then do like final thoughts, but just my comments on what Brian raised in terms of talking about criminalization and harm reduction and this country's response to all these things. I will say, like, as a healthcare organizer, like I do this work like on the federal level, on local, state level, and I will say like there's absolutely a shift happening right now. I think we're all aware of that, especially with everything that we've been through over the last year and a half. Like there are conversations about shifting from criminalization to harm reduction and public health approaches. So as much as all this is like stressful and like hard to deal with and a burden, it's also like a tremendous opportunity like to be alive right now, to be doing this work. So if people are like emboldened to like be advocates or organizers, the IOCDF has an advocacy team that you can get involved in. The National Alliance on Mental Illness is like very active on this work. My organization, the Center for Popular Democracy, does lots of healthcare work, and you can reach out to me. I'm in charge of it, so I'll plug you in. There's just lots of opportunities. It's a really like great time to be doing that work. So thank you for raising that question, Brian. And then this could work well as the final question, and then maybe we can do some last thoughts. But at 8:09, Allison said, what do you think the best way is to convince a headstrong teen to go full force with exposure therapy? My daughter has severe contamination OCD and is afraid of being disgusting. She's done a lot of therapy, but doesn't do it fully. It's gonna be a good opportunity to give your last pitch for treatment, for ERP, for walking into that forest. As I said, what would your pitch be to Allison's daughter?
So I don't know. Do you guys want to go first? I don't want to be. Do you guys want to go?
I mean, I can say something briefly, but I'm not. I imagine that you have a lot more expertise with teens than I do. Is I think it's helpful to help the teen understand what it's costing them. There is a cost to not doing this work, and it's going to be felt. If it might not be felt in this moment where you're choosing to feel safe or to feel comfortable, but there is a huge cost to this, and there probably has already been a cost. And I think this is where an ACT approach, sometimes I think poorly named, but it's called creative hopelessness. This idea of what have you tried that hasn't worked, and what has been taken away from you in your life. Has your life been limited? Your life wants to be this big, and it's this big. And how do we get you from this big to this big? And then I think instinctually they would understand they need to do this work. And then if they can, I think a lot of times group ERP can be incredibly valuable, especially for young folks, when they can sort of turn this into a bit of a game. Let's one up each other with exposures. Let's win points. And that might not be something your daughter can get into or is available, but I think that can be really helpful. So that's just my 2 cents.
So, it's funny because right before here, I was sitting with a bunch of them in the clinic. They're all intensive patients, and I mix them with the residential, and I have a little funny approach. It's not a scare straight, but I like to bring people who are pretty severe and they lost a lot in life to talk with my younger folks. So to say, hey, one day I was in your shoes and don't want to be in my shoes now, so walk the walk right now. So it's a little bit to have the foresight. So when you're a teenager, part of being a teenager is thinking that nothing bad is going to happen, that this is never going to happen to you until you sit in front of someone and you hear their story, and all of a sudden, wow, that sounds so much like me. And this person is here now in residential or intensive, and I don't want to be here. I don't want to have to do this work, right? So I think that there is this concept of really seeing the reality and understanding that your condition is progressive. So people understand very quickly that if, God forbid, they have cancer, that they have to take action because cancer will kill you, right? OCD is so pervasive and is so debilitating and devastating. But we know exactly what happened with people that don't get treatment for cancer, because there's a very solid, end to that. But I think understanding what happens when we don't tackle our OCD, and when OCD doesn't go away in a way that we can actually manage our lives. So I'm not saying curing OCD, but really understanding what Vinay was saying, like, I have a thought, I just live with that thought. You know what? It's going to be there. I have OCD. What am I going to do? Right? But that doesn't stop me from doing the things I want. Right? But a lot of times, one thing that parents don't understand is how much accommodation goes around that allows a teenager to stay sick. Right? So remember, as parents, our job is to make our kids feel better, to make them happier, or to make them more functional, or to make them get to places. Right? So if your kid has contamination fears and they're not getting to school, there's going to be a very big push on your part to go ahead and help out to get the kid to school. And that many times does not allow the child and the young adult, teenager, to realize, wow, I can't even do this. I'm starting to not be able to do that. So unfortunately, sometimes parents buffer. They go between life and the kid. And OCD really loves that, because then not only the kid is working for OCD, parents are working for OCD, right? And so even in very skilled parents, even in parents that had a lot of training, I'll walk in, and if I go to the house, which sometimes we do because it needs to be at the house, you see accommodations that the parents didn't even realize. Because when you were in that hole in the thick of it, I'm gonna tell you, I have 3 kids. I would not notice either. It's not a question of knowledge. It's a question of your situation, right? So having that training. So for me at our clinic, for instance, I don't care what age you are. I don't care your situation. Your family, your support system is going to get training. They have to, because they're going to need to know what to do and what not to do in the future. And if they become partners with OCD without noticing, your chances are very, very little. So if Vinay's family or friend is reassuring him all the time and he's not even noticing, that friend is not helping, but it definitely is helping OCD, right? So that part of the accommodation is, to me, so important. I think that a lot of motivational interviewing skills and ACT have been really helpful for a lot of us to work with those guys. But I actually try to get the kid pissed off at OCD. So I actually try to switch their anger, instead of being like oppositional to the parents or oppositional to us, which they love it. I'm not going to tell you my nickname because maybe younger people in this call, and I do not want to curse because I don't think we are allowed to, but it's not good. And what they say is that person said this and that person said that. And I don't mind. I don't want to be popular. I think that none of us want to be popular. We won't want to help, right? And so the idea of having to look bad first to look good later is really an aspect. So I would say that sometimes we have to buy a little bit of the challenge and the fight and take a bullet for the kid, and the sad thing in terms of the world out there is we get bad reviews all the time. So really bad reviews when we don't do what the kids want us to do. But if you're not nervous about that, worried about that, and you're worried about saving a life, the idea is that sometimes strategic pressure is the way to go. So trust me, there are a lot of things kids want. And if it's a value in your house that you take care of your health, and that's important for your family, that helps a lot. And so contingencies, I always say love is unconditional. Everything else is conditional. Everything else needs you to put some effort to get it. And it's not like I'm going to punish you for having OCD, but it's your responsibility to work on your symptoms.
Jelani, any last words, your pitch?
So pitch, I guess one thing that comes to mind, I like utilizing metaphors and in treatment, and with what you had brought up, Vinay, in terms of like the forest, reminds me of a metaphor that I like to utilize, in which you can think of OCD as a sense of being comfortable in one's own discomfort, in a sense of like continue, even though like you may realize that there are a lot of like negatives and struggles and difficulties that come with doing compulsions and avoidance and whatnot. At the same time, one can get very comfortable being in that position and being very scared to do anything that's different. And so I think about like it, you know, apply this to like a metaphor of like being in a forest and say going on a well-traveled trail that may be very difficult and very windy and very treacherous. But at the same time, like, what if we made a new trail? What if we made one that is even more like direct and maybe even like, you know, allows us to reach our destination more efficiently instead of going through like this very windy path? And, you know, in order to do that, though, would require having to say like, you know, move away some branches and you know, tread this path and creating it, like, you know, removing other weeds and grass and whatnot. But like over time, as you continue to do that over and over and over again, traveling down this new path as opposed to this old path, you're creating, you know, it's this new path gets easier to travel on. And so like in the sense of like with OCD and the treatment for OCD, like with exposures, it may seem very difficult at the beginning and being able to, it's like a lot of unknowns and just challenges in doing it. But once you get doing it repetitively over and over and over again, it becomes much easier. And now this old path may still be there to some extent, but then that old path starts to, you know, weed over and becomes less of the one that you travel and see more as like this new path as a better way of being able to travel. And so I like to try to frame it in that way at times and being able to see that it may be difficult to take this new path of doing things differently. But if you allow yourself to do it over and over again and getting used to it, you see that it can be a much better path and it gets easier over time.
Yeah, absolutely. And I guess from a patient's perspective, I guess my pitch would be like the forest metaphor I mentioned before, but just like, I feel like I am on the other side now, like I'm healthier than I've ever been in my life. And like, it's totally worth it. Like it took a long time to get here, but that need we all have to control everything, like being able to set that aside, like to let that go, it's liberating. Like there's no feeling like it. So I hope all of you get there. And just to tie it back into shame, my favorite part of the ICF conference is the keynote address. When we're back in person, I hope we do that again soon. And it doesn't matter who's speaking. Like the first time I did it, I was in a room of like 2,000 people who all understood OCD. And that was huge for me, right? Because like growing up as a kid, I was convinced like I'm the only one thinking these things. I'm filled with shame. I'm a monster. And now I'm in a room with like 2,000 people who all get it. So like that was the first time I've been in a room without shame, right? And like that's liberating. So like when I'm doing my organizing work, I'm trying to think like, how can I get more people to be in a room like that? How can I make that room bigger? I hope this call felt like that kind of room for people on it. And I hope like, you know, we keep doing that work. But yeah, thank you so much to the three panelists who joined us. Thank you everyone for being engaged and asking questions. This is going to be on YouTube after, on Facebook, on IOCDF social media. So if this was useful, please share it. We do lots of events like this. We'll have more of them soon. I'm sure Ethan will be back soon. And yeah, let's keep doing this work. Thank you all so much for this conversation. This is great.
Thank you, everybody. Thank you, Vinay.
Yeah, thanks everyone. Thanks, Vinay.
Thank you so much, Vinay. It was great. Thank you, guys. It's nice to meet you.